Well, I'd like to thank the organizers again for the invitation to be here. It's a pleasure to be able to address you. So my task today was to talk about who's your suspect, and I'll share this with Kevin Winthrop, who'll give the second part of this. Our tasking was to talk about current diagnostic techniques and future techniques in diagnostics, talk a little bit about importance of strain typing and drug sensitivity testing, and then to mention standards of care. Kevin will cover the last part of that. In terms of who to suspect, I think it's important to recognize the company that the disease keeps. And this will overlap some with the previous talks, but the diagnostic techniques, I think, initially start with figuring out why someone's presenting with the symptoms that they have and knowing sort of the associated conditions that can lead to things like bronchiectasis or COPD, and recognizing those as risk factors are important. So if you look at things that relate to impaired local defenses in the lung, structural changes in the lung, you'd be thinking about things like bronchiectasis, emphysema, pneumoconiosis, which are exposure to things like cold, previous cavitary TB, silicosis, and COPD. Many of those things can be picked up by clinical history, especially by chest imaging or pulmonary function tests. And then again, once you recognize those conditions, recognizing those conditions as risk factors for NTM is important. People have mentioned this morning the genetic associated diseases like alpha-1 antitrypsin deficiency, cystic fibrosis. There are genetic and other screens or other testing diagnostic for those. Primary ciliary dyskinesia is probably about 10 years behind cystic fibrosis in things like diagnostic testing and genetics, but they're quickly catching up. And we now know about things like cardinal clinical features that would allow recognizing people at risk for this. There is a bedside measurement of the production of nitric oxide in the nose, which is sort of equivalent to the sweat chloride for diagnosis of cystic fibrosis. That looks like it's a very good screening test. It's not perfect, it's not 100%, but it at least allow you to get people pointed in the right direction. And then other tests like measurements of ciliary beat frequency, looking at the structure of the cilia under an electron microscope, which used to be the gold standard test for this, but we now recognize as genetics are getting better that there are certain gene defects that result in normal appearing cilia that don't move normally. As opposed to cystic fibrosis, where there's one gene, many mutations in it that can cause disease, we're now up over 40 genes that have been associated with human disease with ciliary dyskinesia. And so as opposed to screening a single gene, we're reliant on panels of genes being screened at the same time. And there are commercial vendors who are keeping up pretty well with the research discovery of new genes. There's one panel available at relatively inexpensive costs that'll screen 34 of these genes. And so I think if you couple that with going down a pathway of appropriate clinical symptoms and appropriate screening diagnostic tests, we can get in a better ballpark of finding that diagnosis. There are impairments of systemic immunity. We talked about immunoglobulin levels before. There are certain specific immune deficiency like STAT3 deficiency, which causes a disease called hyper-IgE or Job syndrome. Those patients are very predisposed to developing bronchiectasis, and those who develop it, about a third will develop NTM-associated disease. And so, again, the immunoglobulin screen would generally pick up a very high IgE level that could then lead to further testing. We heard a discussion of immunosuppressant use, particularly TNF-alpha blockers, which are used in diseases like rheumatoid arthritis and inflammatory bowel disease. And drugs that are used post-transplant can predispose patients to NTM as well. And then finally, we're left with a group of patients that we don't understand completely that have been called the Lady Windermere syndrome, and sort of excluding those other conditions and kind of putting together some of the characteristics that we know are associated with that condition may be helpful in suspecting it as well. What we do in terms of diagnostics is really based on these clinical criteria that were put together by the ATS and the IDSA. And the goal here was to try to get around the fact that The symptoms that people present with are very common to other diseases. The radiographic manifestations are common to other diseases. And even occasionally finding a positive culture on a respiratory specimen for mycobacteria, particularly Mycobacterium avium complex, may be due to the presence of these organisms in municipal tap water supplies or in environmental water sources where this can be resident in the upper airway. And so these criteria were devised to try to narrow down a bit those people that we're diagnosing with disease, and they consist of a requirement for appropriate symptoms, and I'll talk about that in a bit more detail, appropriate radiographic findings. Dr. O'Donnell went through some of that, and then exclusion of other diagnoses, things like tuberculosis or even bronchogenic carcinoma or lung cancer, which may mimic some of the findings that we could see on CT scan and produce similar symptoms. From a microbiologic criteria, it requires multiple expectorated sputum specimens. I'll talk a bit more about that to yield a diagnosis to get around this problem of maybe an occasional light positive culture coming up that's not associated with true disease, or if patients don't bring up sputum, the use of bronchoscopy or biopsies. With regard to symptoms, several years ago, the FDA put on a conference in the DC area that some of you may have attended, where they solicited input from patients on factors that they needed to know about that would go into drug development. And I found that one of the most enlightening conferences that I had been to. There were, I would have estimated 100 patients there. They say 50. And I thought there were about 200 on the phone. There were 25, but my ability to estimate numbers is not great, but their voices were very loud and clear about the things that impacted their day-to-day lives. And as a clinician who's taken care of this disease for over 25 years, there were many things I learned from that I didn't know. And with regard to the symptoms, one of the questions was, what's the symptom that bothers you the most? And there were three that sort of stood out. A majority of people listed coughing as one of those symptoms, and that included things like coughing up blood and phlegm or mucus. They identified triggers that set this off, things like changes in weather, talking, strong sprays or fumes, physical exertion, dust inhalation. And some of the descriptors, and by the way, this report is available online. I put a reference down at the bottom, but if you just Google FDA patient-focused drug development, NTM, this will come up. And the report is very nice. It summarized what went on at that conference. But there are quotes in there from patients talking about things like disabling cough that resulted in rib fractures, or not being able to go out in public because of the paroxysms of cough that would come on unexpectedly. Another symptom that a majority of the patients described was fatigue, and some of the testimonies described this overwhelming fatigue that kept them from doing day-to-day activities, kept them from doing things like driving. And they described it as from feeling like tired to your core to walking through molasses, which I thought was an interesting description. They felt they often had to allocate their energy to manage the fatigue. And a quote that I thought was particularly striking is, "My day is based on personal energy. I plan out what I'm going to do based on how I feel." And then the third one was that a little less than a majority noted shortness of breath as their most prominent feature. And they found that often requires them to pace themselves to avoid feeling winded. And they also noted triggers for this, things like sense, walking, talking, and any physical exertion that they may participate in. From a radiographic standpoint, we have tended to classify this disease based on the types of findings, and we've generally talked about two different classifications. Dr. Koh, who's in the audience, has recently published on sort of an in-the-middle part. You know, we talk about fibrocavitary disease, we talk about nodular bronchiectasis, and there are also patients that have bronchiectasis associated with cavities. And those cavities tend to be associated with more severe disease. Classically, this was described in male smokers with upper lobe predominant emphysema, and these are characterized by large burdens of organisms. It's difficult to treat, difficult to get drugs to penetrate into those cavitary walls. And the pathogenesis, why people develop this, is not difficult to understand. These are generally areas where the typical protective barriers are destroyed, and these organisms can take up residence and multiply in a relatively protected environment. The Lady Windermere syndrome came from this publication back in 1992, and it described patients with predominantly a right upper lobe and lingular involvement, these anterior locations in the lung. But many of these patients typically have involvement elsewhere, like this patient with involvement in the lower lobes as well. And they're not all women. We've recently done a study looking at trying to identify Lord Windermere. And when we purposely go out and try to recruit men into this, we can find them, and many of these characteristics overlap. And so we're a little confused. We don't know if there's differences in the way men and women access care, if women are more likely to come to our research institutions and be in these studies. But I just want to make the point that not everybody fits this mold of being postmenopausal women, non-smokers presenting with chronic cough. From a microbiologic standpoint, as Dr. Ajemian mentioned, these organisms are ubiquitous in the environment. They're in our water, they're in soil, they're in our municipal water supplies. There are many, many different species, mostly related in recent years to improvement in molecular microbiology and identifying them. But there are really 5 species that account for the majority of disease and most of what we're talking about, which I listed there. And the vast majority of disease associated with these occur in the lung. So right now, our standard of care for diagnosing this is to get a respiratory tract specimen. And generally, we're talking about expectorated sputum. In general, my personal opinion is that is preferable to bronchoscopy, because if you can get sputum, it's generally sampling from those areas with greatest inflammation. It's not as invasive of a procedure, and it's something that you can check repeatedly over the course of the treatment. Ideally, according to the criteria, if you can get 3 early morning produced specimens on different days, you'd then be looking for recovery of the same species on more than one specimen. We do a lot of induced sputum, and I know that this is difficult to get in places that are not used to doing it. It's usually thought of as a test for TB or as a test for other things besides looking for non-tuberculous mycobacteria. But I can tell you that it can be done safely and effectively using the same hypertonic saline and airway clearance devices that we prescribe to patients with bronchiectasis as part of their treatment. And a number of years ago, when we set our clinic up at the NIH, our nurses came to us and said, "We noticed that your patients leave the clinic a lot. They go get CAT scans, they go to pulmonary function, they go get sputum induction." They're like, "Why can't we do this sputum induction here?" And so we basically set it up with nothing fancy. It's basically the same things we're recommending as treatment, and why not have the patient do that when they come to see us in clinic? And it's generally highly effective at getting the sputum from them. And I think something that in places that manage this disease a lot really ought to make an effort to try to set up. The other thing that we and other places do, and we've done this in the setting of clinical trials, and it is very effective in getting specimens, is to set up a system for send-in sputums to allow for home collection. Again, these things we're preaching to patients about trying to do for airway clearance can be effective at obtaining the samples we need to make diagnosis and following patients on treatment. If it's refrigerated and sent overnight by courier, it kind of helps to decrease the amount of overgrowth of faster-growing bacteria, but it may take some logistics to get that set up. In terms of bronchoscopy, I think the possible indications for this is the inability to collect sputum or to exclude those other diagnoses. In that CAT scan I showed you previously, that patient doctors had an initial concern for bronchogenic carcinoma. They started with a biopsy. The biopsy showed changes that looked like mycobacterium. They then went back and got a culture from sputum that showed a lot of Mycobacterium avium complex. So it can be helpful, but if they're going to do a biopsy on the patients, it's important that the surgeons or the bronchoscopist submits those samples for culture and doesn't put the entire biopsy into formalin, which then doesn't allow mycobacteria to grow out. In terms of the future, it's hard to predict, but there are certain things that I think would be very helpful. From a respiratory tract samples, it takes a long time to get results back from this. The smears that we do take about 24 hours to turn around. That can give you an idea if there's mycobacteria there in relatively large quantities, but the cultures can take up to weeks to grow out. On the TB side, there are direct detection techniques that can not only tell you that the patient has TB, but can also tell you a little bit about the susceptibility or resistance to a major drug that is effective in treating this, rifampin. We're not quite there yet for NTM, but at least the concept is in place, and I think it's reasonable to expect that there could be development to allow this kind of rapid diagnostics on sputum testing. Ideally, it would be nice to have a blood test to diagnose this. It's not easy, simple, or pleasant to collect sputum from everyone, and if we had a way to collect blood that would help us not only with diagnostics, but would help with following the patients, telling who has active disease and who doesn't, I think that would be a major breakthrough. We've worked with an investigator, Tony Yu at Arizona State University, who's developed the technology shown at the bottom of this slide, where on a blood sample you can microwave it, you can put it in a substance, tryptase, that breaks up proteins in it, that will separate out these peptide fragments of antigens that are secreted by mycobacteria into the blood. You then put that through a series of steps that include these nanoparticle discs that have antibodies attached to them that increases the specificity of finding these peptides that are put in along with internal standards that allow you to quantitate the amount that's there. So you get information back, and then this is analyzed on mass spectroscopy. This gives you an ability to have a very high sensitivity of detecting this, and with the internal control fragments in there, it allows you to quantitate the amount of it there. And so in this study that was published recently, it allowed us to be able to distinguish between active tuberculosis and sort of latent tuberculosis, and it also showed a correlation with treatment with a decrease in the fragments that were detected over time as the patient began to improve. Our participation in this was to provide non-tuberculous mycobacteria as a control, and while this test showed very high specificity for TB, there may be ways of restructuring this to add or to allow for specificity for NTM with this type of testing as well. Again, the future, don't know if this will actually work out, but at least something to think about. I was also asked to talk about things like strain typing and antibiotic susceptibility testing. Well, the latter I won't talk about because Dr. Saufinger will cover, but I'd just like to point out that patients followed over time, and this has been an interest in our lab from looking at the standpoint of host adaptation of these mycobacteria in the airway. We and others have noticed that patients acquire multiple different species, subspecies, and strains of mycobacteria. So the mycobacteria that's found when you originally start out with your diagnosis is not necessarily the mycobacteria that you're going to keep over time. Whatever predisposes you to that original infection doesn't go away yet, and so you just keep getting exposed and more there. Well, the culture techniques that we do and the current means of identification of species aren't really adequate to be able to tell you that about all of these changes going on over time. And we and others have looked at serial changes going on in these isolates from patients and noticed that some of these changes are important in that it either causes changes in genes that may affect the ability to respond to antibiotics. They may acquire these mutations even if you keep the same strain, or those different strains that you acquire may have different susceptibility tests. And this can affect the determination after treatment about whether if somebody's got a microbiologic recurrence, whether that's a relapse or a reinfection, which can be an important thing to know because it dictates how treatment will be done. And it can also be important for interpretation of clinical trial results. If you've got somebody in a clinical trial that looks like they have culture converted, and then you follow them up at a later time and they have a positive culture, you don't know if that's a failure of your investigational drug or if they've been infected because they can't get away from being exposed to the environment. So I think that these things are important. How they'll factor into clinical care is not quite clear, and I'd just like to end with acknowledging the super team that I get to work with, especially my partner Kevin Finley, who today is back at the NIHC clinic before he travels here tomorrow. Thank you very much.